Right, everybody. Welcome to another Expert Talk. And this one is going to touch you today. This is a practical way to make your life a little bit better. It's called palliative care. And, I just want to suggest after you hear the program tonight, you might want to contact a Pathfinder to be part of your team. And with that, and one last thing, we'll have the Pathfinder email in the chat. And that would be everythingals.org/pathfinders, and you'll find all of us. Okay, and with that, Indu?
Yeah, I just wanted to say thank you very much for everybody joining us today. And we are really excited to bring in Kara here. And I will pass it on to my team to introduce Kara's background, and really excited to have all of you share this evening, and also knowledge. I mean, that's very important. And as you know, we have an app, Everything ALS app. If you go to our Everything ALS website, you'll see a lot of information which can actually, not only you can do research, you also can get into nutrition, managing your health as well. So as we say, it's a care to cure. If we don't care about you, we can't come to the cure. So our goal is to really start with caring about each one of us, to you, and also each other. So with that, I think I'm going to pass it on to my team, Christian and Anusha here.
All right. Thanks, Indu. Welcome everybody to today's program. Today's program is a really special one, as the team's been talking about. So it's titled Palliative Care for ALS. What is it? How can it help? And how to access it, with Dr. Kara Bischoff. Dr. Kara Bischoff is the Associate Division Chief of Outpatient Palliative Care and the Medical Director of Outpatient Palliative Care Service at the University of California, San Francisco, or UCSF. Dr. Bischoff has developed a particular expertise in palliative care for people with amyotrophic lateral sclerosis, ALS, and has published substantially on outpatient palliative care for people with illnesses other than cancer. She's been recognized as an emerging leader in palliative care medicine by the American Association of Hospice and Palliative Medicine. Dr. Bischoff earned her medical degree from Harvard Medical School, followed by a residency and chief residency at UCSF in internal medicine, and has also did her fellowship in hospice and palliative medicine at UCSF. Kara is a mother, an outdoor enthusiast, and a San Francisco Bay Area native. And we're really excited to have her here. Thank you so much, Dr. Bischoff, for joining us. So I'll turn it over to you.
Thank you so much. I really appreciate the invitation. I'm glad to be with you all, especially at this late hour of the day for many of you. So thank you for your time and attention. So as mentioned, I'm a palliative care physician at UCSF, and I've been working closely with the ALS team since 2017. And this wasn't a disease that I knew a lot about before I started this work, having trained in internal medicine. But I've found through my experience partnering with the ALS team and caring for so many people like yourselves, that this is a really extraordinary illness, and it touches a lot of extraordinary people. And I found it to be such meaningful work, where people have a lot of needs, including needs for palliative care, and where our team has been able to make a difference. And it's just felt incredibly, incredibly meaningful as well as hard. And I wanted to share with you a little bit about what we've been doing, what is palliative care, and how you might access it. So I'll share my screen and I'll do presenter view. The idea behind palliative care is essentially helping people live fully and live well with a serious illness. And as a matter of disclosures, I just wanted to mention that I do have funding from the ALS Association to study palliative care for ALS, and I've done a number of studies in recent years. So briefly, what is palliative care? In a short sentence, it is care focused on improving quality of life for people living with a serious illness. And I want to emphasize that it can be provided alongside life-prolonging treatments at any stage of a serious illness. So I really want to distinguish it from end-of-life care or hospice care, which have some similarities, but also some differences in that palliative care can be provided from the time of diagnosis and alongside other disease modifying or curative treatments. And when we describe palliative care, we sometimes describe it as having three main buckets that we address. First, we address symptom management. So we try to help people with physical and mood symptoms. So physical symptoms might be pain, might be shortness of breath, might be constipation, might be insomnia. Mood symptoms might include depression and anxiety, grief and loss. The second big bucket that we help people with is care planning, making sure that people have the information they want and need about their illness and about what's likely to come in the future. And they have support to make decisions about their care. And then the third bucket is emotional support. I realize that's sort of a vague and broad term, but both for patients and family members or other care partners, we try to provide emotional support throughout the journey. So it's a very high level, bit of information about palliative care. I'm trying to advance this slide here. Here we go. So just to say a little bit more about this, palliative care is definitely multidisciplinary team care. So in our clinic, it's provided by doctors, nurses, social workers, and spiritual care providers working side by side, all available to the patient and the family, broadly defined. There's dedicated attention to symptom management, and I realize the ALS team may address symptoms also, but the palliative care clinic is a place where you have a little bit more time and space and focus on the symptoms specifically. Additional time and staffing for emotional support as well. Our social worker and spiritual care provider do a lot of this. We're trained in serious illness communication, talking about the difficult topics, making sure we understand people's values and priorities, what's most important to you, what are your hopes and worries for the future, so that we can help you make decisions about your care that are grounded in what's most important to you. There's also extra time and attention to care coordination, realizing that we all, live and work in a nutty healthcare system, and it's not always obvious how to get the help you need and how to coordinate your care. So we try to help with that. And we help to transition people to end-of-life care, which may include hospice care when the time comes. So there is some evidence for palliative care for ALS. I wanted to share just a little bit about this, though it's not the main focus of this talk, but there was a randomized controlled trial done in Italy, actually, of palliative care for people with neurologic illnesses, including ALS. And they showed that there was an improvement in pain, shortness of breath, bowel symptoms like constipation, sleep, and importantly, quality of life for the people who got early palliative care compared to people who got late palliative care. There was a second randomized controlled trial done in the UK of palliative care for people with neurologic illnesses that also showed improved symptoms as well as satisfaction with care for people who received palliative care alongside their other neurologic care. We did a cohort study at UCSF, and we showed that having concurrent palliative care alongside ALS care helped with needs in multiple domains, including physical symptoms, psychosocial and spiritual concerns, led to more consistent advanced care planning, documentation, and addressed care partner needs. And with palliative care, we found that rates of advanced care planning increased and use of hospice was common for people near the end of life. And then there have been a couple other studies, one out of UCLA, one out of the Mass General Hospital in Boston, that have shown that integrating a palliative care physician into the multidisciplinary ALS team can help with physical and mood symptoms and also help support care decisions. So there is this emerging evidence about the benefits of integrating palliative care into ALS care throughout the illness. And I wanted to bring this to life by telling you a little bit about a case. I imagine a case like this might be familiar to many of you. So Mr. R is a 59-year-old man who loves to run. And one day when he had a near fall while running and then developed low back pain that persisted, he didn't think too much of it, just thought he was aging and had an injury, tried to ignore it. But over months, he began to feel less stable and he was no longer able to run. He had an evaluation with a spine surgeon 6 months later, was treated with an anti-inflammatory injection in his low back, but unfortunately his weakness continued to progress. He was then referred to see neurology a full year after his initial fall, and the neurologist noticed that in addition to his limb weakness, he had lost weight. He reported that it took him longer to chew and swallow. He had mild shortness of breath at night and associated anxiety. He was ultimately diagnosed with limb onset ALS. So unfortunately, very common story, multiple symptoms over a long period of time leading to this diagnosis. And the challenges associated with ALS, I'm sure, are not familiar to any of you. There's a high symptom burden, many different physical symptoms as well as mood symptoms. There's difficulty with communication, which can be particularly challenging. There's this protracted stepwise decline, uncertainty about the future. There's complex decision making faced throughout the illness, and high caregiving needs. I don't have to emphasize any of that, I'm sure you know. But the goals of palliative care are really to address all of that. So trying to alleviate symptoms and improve comfort in any ways possible, trying to enhance emotional and psychological well-being in the face of this illness, trying to facilitate communication and decision making, and trying to support patients and families throughout the entire journey. So to pause briefly, would anyone like to call out, or if you feel comfortable doing so, truth or myth? People must stop seeing their ALS team if they're receiving palliative care. Any guesses? Anyone want to?
False.
Myth.
Yes? Myth. Okay. I think I heard a myth in there.
You did.
Yes, that's right. So people do not have to stop seeing their ALS team if they're receiving palliative care. Palliative care can be provided alongside ALS care or disease modifying care from the time of diagnosis. So thank you. We're all paying attention. And it's different than hospice in that way, which is really a program for end of life care that people transition to when they're no longer receiving other types of medical care. So that's right. And another one, people cannot continue ALS treatments when receiving palliative care.
Myth.
Correct. This too is a myth. I think sometimes people hear palliative care and they imagine, oh gosh, that it must be that the person is getting only comfort focused treatments. But no, you can continue disease modifying treatments while receiving palliative care. And palliative care is appropriate for people regardless of your goals. It's not only for people who want to prioritize comfort over life prolongation. Many people who receive palliative care actually want to do anything possible to extend their life for as long as possible, but they also want to attend to their quality of life and comfort in the process. So the old model of care was kind of to receive disease-directed care throughout the majority of an illness, and then palliative care would come in that blue wedge near the end of life as people got sicker, and then people would transition to hospice care. But the newer model is really to bring palliative care in from the time of diagnosis, provide it alongside disease-directed care, in this case ALS care. It does tend to ramp up a bit as the illness progresses, and then people may transition to hospice care, and hopefully the family will receive bereavement care after a death as well. So to just come back to our case, Mr. R continued to struggle with his breathing and anxiety. He was started on a non-invasive ventilator, which helped his breathing and energy somewhat. He also received a low-dose opioid as needed for severe episodes of shortness of breath. And anti-anxiety medicines were started. He also met with the palliative care social worker for counseling. And the social worker met with his family for support around adjusting to the caregiving role. So I just want to highlight here, in this case, how we often help people with, alongside the ALS team by prescribing medicines, like perhaps a low-dose opioid for shortness of breath or pain, by prescribing antidepressants or anti-anxiety medications when indicated. We also frequently prescribe medicines for constipation, for sleep, etc. And as I mentioned briefly, our palliative care social worker and spiritual care provider frequently meet with people with the illness or their family members for supportive counseling and to help them with adjustment to all the myriad changes that are dealt by this illness. And by 1.5 years after his fall, unfortunately, Mr. R was losing weight and his ALS team recommended a feeding tube, but he felt very ambivalent about this and unsure whether that was the right choice for him. So this is another way that the palliative care team can help, providing an extra layer of support to help people think through these complex decisions that are so common in ALS. Those might be decisions around whether to have a feeding tube placed, whether to proceed to invasive ventilation through a tracheostomy, for example, whether to receive resuscitation should one's heart stop, whether to try various communication devices, etc. So advanced care planning in ALS, we really think of as happening from day one, from early in the illness. And we start in our palliative care visits by trying to get to know people as human beings, understand their values and priorities, what's most important to them, what brings them joy. And we also use this question a lot. As you look to the future, what are you hoping for? Trying to understand what feels most important to people in the face of their illness. We also often ask the paired question of, and as you look to the future, what are you worried about? Because that too can be really important and revealing. We want to try to address the concerns that are weighing on people's hearts and minds. Another early question that we often ask is, if you weren't able to make or communicate your own healthcare decisions, is there someone who you would trust to speak on your behalf? And particularly since communication challenges can often come up in this illness, we try to really clarify who would that person be, who could serve as a durable power of attorney for healthcare, also known as a surrogate decision maker, and encourage them to talk to that person about what kind of care they would want or not want, so that person can really use substituted judgment and make decisions on their behalf. Just as a brief aside, if no one's named, decisions are deferred to a default surrogate. So in many states, there's a legal hierarchy in who healthcare professionals turn to in the absence of a named DPOA or surrogate decision maker, which usually is a spouse or partner, and then an adult child, and then a parent if a parent is living, etc. In the state of California where I practice, we don't actually have a legal hierarchy, but it's instead the responsibility of the healthcare team to try to determine who seems to know this person best and be available to make decisions on their behalf. But you can see that this is imperfect. It's better for the person with the illness to be able to designate who they'd like to make decisions for them in advance of needing that. And that surrogate decision maker is documented in an advance directive. So the advance directive is a legal document. We help many people complete these in our clinic. It doesn't have to be completed by a lawyer. It can be completed by a person with a serious illness or a healthcare professional with that person. And it's a really important way to designate, legally designate a surrogate decision maker and to indicate what kind of end-of-life care you would want if you are seriously ill and unlikely to improve. I also wanted to emphasize that this is a living document. It can be updated at any time and should be updated if your wishes change. So I think a lot of people say, oh yeah, I have an advance directive. I did it about 4 decades ago with a lawyer. Not sure where it is, but that may or may not reflect your current wishes. So I think it's important to pull these things out, dust them off, take a look and see if they still reflect your wishes. There's a lot of different advance directive forms. One of them is pictured here, the 5 Wishes document, which is one of the more detailed advance directives. Some people love it because it asks lots of probing questions, gives them lots of opportunities to think about different scenarios and express their wishes. For other people, it's totally overwhelming. I might be in the latter camp personally, but there's different types of advance directive forms for different people. There's also an advanced directive website called Prepare for Your Care. It's prepareforyourcare.org that was created by a group based out of the San Francisco VA. And this sort of walks you through the steps of creating an advance directive on this interactive website, and pops out an advance directive at the end of it. So can be a nice option, but I also wanted to mention that there's a number of similar documents and advanced care planning guides that are specific to ALS. For example, this one that was created by the Unity Hospice team. They have a particular interest and focus in ALS, and it does ask a lot of great questions to help you organize your thinking in advanced care planning for ALS specifically. The palliative care team also tries to make sure that you have the information you want and need about any specific treatment options that you may face, like a feeding tube, tracheostomy, resuscitation, whether you'd want to go to the hospital if you were to get sicker, go back to the hospital if you've been to the hospital frequently. So this is not distinct from what the ALS team is doing. They may also counsel you about these options, but I think sometimes people feel that it's helpful to have a second, team, a sort of more neutral space and perhaps a little bit more time to think through these decisions. And the palliative care team really tries to understand who you are as a person, as a family, what are your values and priorities, and then provide recommendations that are grounded in those values and priorities. And the palliative care team frequently talks about the option of hospice for people who are nearing the end of life. What is this? How could it be helpful? When is the right time? And helps with that transition. So to do a brief aside here on hospice care, this is a program that's appropriate for people with a prognosis of 6 months or less. So different than palliative care, and this is really end-of-life care. And the focus in hospice is exclusively on comfort, not on life prolongation. So when you're in hospice care, they will cover medicines for comfort, but they won't cover disease-modifying medications, like Radicava, for example. So when's the right time for hospice? There are requirements to enter a hospice program that relate to the requirement of having a 6-month prognosis, which include having respiratory weakness, for example, a forced vital capacity of less than 30%, or a rapid decline in one's forced vital capacity, or significant weight loss, like greater than 10% weight loss in 6 months, or other life-threatening complications like a hospital admission for a pneumonia, for example, and a person wanting to focus on comfort and stay in place. Usually that's at home, but if people are in a facility and living there, they could receive hospice in that facility in most cases, and not want to go back to the hospital. Because again, the hospice philosophy is sort of to keep people comfortable, peaceful, and in place, and not bring people back to the hospital if they were to get a fever, for example, not put them through more workup, more lab tests or x-rays or imaging or IV antibiotics, but rather to sort of accept what is happening and to keep people comfortable and peaceful at home. So it is different than palliative care in that it's only appropriate for people with that philosophy and that set of priorities. So a quick question for you, and make sure you're all with me. Truth or myth, people cannot continue ALS medications in hospice? Maybe I should say ALS disease-modifying medications.
True.
Oh,
True. That's right. So in general, the ALS medications, Riluzole, Radicava, get stopped when someone transitions to hospice. So what to expect from hospice care? Attentive symptom management, people who are really committed to this and expert at this. The hospice team is led by a nurse who comes to your home, usually makes weekly visits, and really tries to address symptoms aggressively. Easier access to symptom management medications, medical supplies, and some equipment. So they can get meds delivered to your home. They can get a hospital bed much more easily than you can outside of hospice care. But I say some equipment because The specialized and expensive equipment like power wheelchairs or a speech generating device are actually not easy to get on hospice, typically cannot be obtained on hospice. But other medical equipment like a hospital bed, a bedside commode, etc., is easier to get on hospice. So you definitely want to talk to your doctors to make sure you have the expensive, complex or specialized equipment that you might need before starting on hospice. The hospice team typically makes home visits and they have 24/7 phone availability. They can make after hours visits if needed. For people with ALS, they generally will continue tube feeds if those are important to someone's comfort and quality of life, which they typically are. They usually will continue BiPAP, but often don't provide non-invasive ventilation. And I realize that's complicated. BiPAP is just sort of a simpler machine, and the hospice teams often don't feel expert at managing the non-invasive ventilators, but can do BiPAP. So, and occasionally we can make an argument for someone needing to keep their non-invasive ventilator because it's been the only thing that has managed their shortness of breath, rather than switching someone to BiPAP upon a hospice transition. They usually provide a lot of support to family members and other care partners, with these frequent visits in the home. They do provide grief support for bereaved family members as well for up to a year. What not to expect in hospice care, I think that there's this myth that once you're on hospice, a nurse is going to come to your home and provide direct hands-on care to you every day, and that's not the case. They come for discrete visits for maybe an hour, possibly a little longer, generally every week, sometimes more often as needed, but nobody's there providing the direct hands-on care for 6, 8, or more hours a day. As we talked about, they don't provide ALS medications that are aimed at prolonging life. They don't do blood work or imaging typically. Instead, they assess people clinically, listening to their symptoms, doing a physical exam to try to determine what's going on and how to best address it, rather than doing a lot of diagnostic workup. They don't provide rehabilitation services like physical therapy, occupational therapy, speech therapy, respiratory therapy. Unfortunately, I think that's really too bad for people with ALS, but it's not part of the hospice benefit. They also don't provide the expensive specialized equipment like we talked about. And generally, they don't provide hospital care except when that's needed to manage symptoms. Like if a symptom is really out of control and the hospice team has determined that it can't be managed at home, then there can be an admission for symptom management, but not routine hospital care. So one more truth or myth question. People must change their code status to do not resuscitate to enroll in hospice. Do you have to say, I am okay with being do not resuscitate, DNR, to enroll in hospice?
I would say that's a myth.
You're right. Yeah, you are spot on. It is a myth, and it's a bit confusing because in general, the hospice philosophy is about keeping people comfortable and peaceful in their homes and allowing nature to take its course. But an exception is that some people really feel strongly that they want an attempt at resuscitation if their heart were to stop, if it weren't to pump blood effectively, and people are allowed to make that choice. It's sort of a funny little oddity of our medical system that we always allow people that choice. So it's not a requirement to be a DNR to enroll in hospice. Most people move into a hospice facility when they enroll. Truth or myth?
Myth.
Myth. That's right. Yeah, most hospice care is provided at home. I think some people imagine that hospice is a place you go, and there are some residential hospice houses where people can receive hospice care specifically outside their home, but most hospice care is provided at home. If someone's residing in a long-term care facility, they likely have a hospice waiver and can provide hospice care there, but it's not the most typical thing to go to a facility for hospice. So yeah, where do you go for hospice? Wherever you call home, basically. So I really want to leave plenty of time for discussion. But before I do that, I wanted to include here a few resources about palliative care. This handout shown on the right is from the ALS Association, and it's 10 things to know to understand palliative care. In case that's helpful, if you want to share it with anyone in your life, there's also pages and many other organizations' websites about palliative care. And there's an organization called the INPCS, International Neuropalliative Care Society, that I just wanted to mention. If you're interested in really getting involved in research or advocacy to understand the value of palliative care, how it can be best applied to this population, I'd welcome you to get involved and in our Palliative Care for ALS working group within INPCS. So how do you get palliative care? It is a medical specialty like cardiology or, rheumatology, and it does require a doctor's referral. So you can ask any of your doctors, whether that's your ALS doctor or your primary care doctor, for a referral to a palliative care program that would likely be within your health system, wherever you get the bulk of your medical care. Although some health systems don't have much outpatient palliative care for people with illnesses other than cancer. Palliative care really did grow up out of the oncology environment, and still there's most outpatient palliative care within cancer centers. But hopefully your doctor would be able to refer you to an outpatient palliative care program that cares for people with ALS, either within your health system or outside it. It is covered by insurance like other medical specialty visits. Usually there's a copay, like $20 for the visit. Usually this does get you the whole team, doctor, nurse, social worker, spiritual care provider, so you're not paying extra for those additional services. Palliative care can be delivered in clinic, in the home, or increasingly by video. So we used to provide the majority of our outpatient palliative care services in clinic, and we were co-located with the ALS team for a period of time before COVID. And then during the pandemic, we started offering our services via video, and that's how the majority of people prefer to receive them. Certainly the majority of people with ALS, since there's, they're a wide geographic sort of catchment area that comes to our ALS clinic, and mobility, of course, is a concern. So we do reach a lot of people in all corners of the state of California by video. And then there are certain programs that do a lot of home visits. Ours doesn't do a lot of that because, again, our patients are so spread out, but that can be a nice advantage. And the visit frequency and palliative care is typically matched to needs. So usually we see people every month or two. If people are pretty stable, we might space that out to every 3 months. If there's a lot of symptoms we're helping to manage, we usually see people at least monthly, and that can ramp up if needs increase. So to just have one summary slide about how palliative care complements and is distinct from ALS care, because certainly there's a lot of overlap and people are understandably, don't always feel clear about this. The ALS team really focuses on diagnosing the illness, providing education about the illness. They talk to people about genetic testing, understanding one's risk factors and family members' risk factors, tracking the illness over time, including using the ALS functional rating scale. They prescribe disease-modifying treatments like Riluzole and Radicava, as well as equipment like wheelchairs and neck support and speech generating devices, et cetera, et cetera. They also do some symptom management, talking to people about muscle cramps, for example, and provide support and connection to community resources. The palliative care team has some overlap, so manages physical and mood symptoms as a more primary focus compared to the ALS team. Also sees the provision of emotional support as a really important core component of what we do, and trying to promote healthy coping, trying to help people live as well as possible in the face of this illness, which of course is so difficult. We provide extra bandwidth and time and energy on advanced care planning and sort of making sure that people can prepare for the future in a way that feels of interest to them. We also provide additional time and space to consider specific treatment options that you may face, to support family members and other care partners. And we talk to people about the transition to hospice and other end-of-life care, including medical aid in dying in areas where that's legal. So lots of overlap, also some distinctions. In my experience, they can be really complementary types of care. I know my colleagues in the ALS clinic feel the same way and feel that palliative care really extends what their team is able to do and complements it well. But I don't mean to suggest that palliative care is the only team managing symptoms or counseling people about their treatment options, etc. So thank you so much. And I really intentionally wanted to leave plenty of time for questions and discussion.
Thank you so much, Dr. Bischoff. That was a fantastic presentation. Lots of questions came in as well. And I think it's going to be a pretty robust conversation from here. I'm going to invite our student ambassadors who join us for all of our expert talks to actually help lead the conversation and moderate the Q&A. We'll be here as well. But so I'm going to ask Alex and Anusha to take over from here.
All right, great. Thank you. So I think the first question on top of everyone's mind is that, thank you so much for sharing everything. What can we do to make it more accessible? So I think, a lot of patients don't live in places where palliative care is super accessible. There aren't a ton of specialists. What can we be doing, and how can those patients go about trying to access care in those areas?
Absolutely. So I'm very actively working with the ALS Association to develop a directory that's going to be on their website of palliative care programs that have experience caring for people with ALS and a particular expertise in this area. We're actually meeting on Friday after a couple other meetings. So we're mid-course in trying to get this thing built. And we do have a lot of different programs in multiple, many states. That are going to be in this directory to help people understand where are the programs, the outpatient palliative care programs with particular expertise in this population, because we realize there are a lot of palliative care programs that focus mostly on people with cancer, and that's a different beast. So stay tuned. I'd be happy to circle back to any of you, whoever is the right person, to give you an update on that directory when it's built, hopefully in the coming months. And then I also wanted to mention that we have this Palliative Care for ALS working group that's housed within the International Neuropalliative Care Society, the INPCS that I mentioned. And we've done a couple things in recent years. We surveyed ALS clinicians about palliative care for ALS. We surveyed palliative care clinicians about ALS, and then we surveyed patients and care partners about palliative care for ALS. And we learned a lot in terms of what do people know? What do they not know? What do they need more information about? What's working and what's not working. And we're sort of systematically trying to step through each of those different things that we learned and address them. So one thing we learned is that palliative care providers, though they are very interested in serving people with ALS, they feel the gaps in their knowledge. They don't know enough about ALS because it's a rare illness. And so we're very consciously trying to provide more education to palliative care clinicians about ALS so that they feel more empowered and informed and prepared to care for these folks. And then we're trying to educate ALS clinicians about what is palliative care, what is the evidence for its benefit, how can it help you help your patients, so that ALS doctors are more likely to offer it and integrate it into the care they provide. And we're trying to reach a lot of patients and care partners as well, like yourselves, to try to explain what this is. And like I mentioned, get your ideas for how it can be improved. And try to bring it to people that way. So I can't say that it's available everywhere yet, but I think it is available a lot of places, aided by the fact that we're providing a lot of this care by telemedicine. So I can provide care as a palliative care specialist to anyone across California, not just within my health system. And we're trying to help people find it through building this directory on the ALS Association website. And we'd encourage you to ask your doctor for a referral to a palliative care program. And your doctor might be misinformed about palliative care, and they may conflate it with hospice care too. You could say, I'm not asking about this because I am ready to throw in the towel, but rather because I understand palliative care can help people live well for as long as possible in the face of a serious illness. That's what I'm really hoping for, to manage my symptoms, get support, and help me live as well as possible. So I don't know if any of that helps, or if there's additional questions on that topic.
No, that's perfect. Thank you. No, that was great.
Thank you. Our next question is, should a palliative care team see all patients considering NIV?
Good question. Yeah, so, you know, it's a tough one. I think some people would say there is evidence for palliative care being helpful for people with ALS, and perhaps everyone with ALS should meet a palliative care team. And that's actually in those surveys that I described our team doing, but with ALS clinicians, palliative care clinicians, and patients and family members. Most people thought palliative care should be offered to everyone with ALS, and that everyone with ALS should meet someone from palliative care. Maybe they don't feel like they need to see them frequently, but to at least know about that resource, have a face to the name, and be able to contact them when needed. So I think, yeah, probably everyone who's considering non-invasive ventilation, which, says something about the severity of the illness and the prognosis, probably should meet a palliative care provider. That being said, I realize this illness is overwhelming. You can only do so much. So despite what the survey said, sort of what my heart says is like, if you feel like you have the support you want and need to manage your symptoms, to get support, to get help making decisions about your care in your existing care team, then great. Maybe you don't need palliative care. But if you feel like you need more help and more dedicated attention to symptoms, whether those are physical or emotional, or you just feeling like you need more support, more guidance, help navigating the healthcare system, then palliative care may be helpful and appropriate.
Thank you.
Yeah.
Great. Thank you. So the next question is, does involving palliative care affect your eligibility for a clinical trial or an early access program?
Thank you for asking. No, it doesn't. Maybe I should add that to my talk, but not at all. We have many people who are in palliative care who are also on clinical trials. Yeah, nothing that's disqualifying at all about that. So palliative care can be provided from the time of diagnosis and alongside all disease modifying or curative treatments.
Great.
Yeah.
What is the situation regarding insurance coverage for palliative care? I know you touched on that a bit, but.
Sure. Yeah, worth reiterating because people ask about this all the time. It is covered by most insurance plans, just like other medical specialty care. There are some complications though, like for some managed Medi-Cal plans, that's Medicaid. In California, we call it Medi-Cal, but for some managed Medicaid plans, they want you to get palliative care in your county if the service exists. So there's some plans that have restrictions like that, where they want you to get care within your network if that care exists. It's sometimes tricky because there may be outpatient palliative care in your network, but it might not be outpatient palliative care that's particularly experienced with ALS. So if you want to get the outpatient palliative care that's, embedded and perhaps in collaborating with your ALS team, it's possible that that wouldn't be in network. But for most people who are seen in our clinic, almost everybody has Medicare and we can see almost everybody. So it is covered by the vast majority of medical plans. And that, covers our full interdisciplinary team. So there's no extra charge for people to meet one-on-one with our social worker, or for a family member to meet one-on-one with a social worker for counseling, or for, kind of practical preparation and things like that, talking about caregiver distress or burnout or anything of the sort. So I think a lot of people imagine there might be an extra charge for the counseling visits, and usually palliative care comes as a package deal, and there isn't an extra charge.
Thank you.
Yeah. I would also say one
So
other
I
thing I
think
probably could have
so
put
a
in my,
concern.
oops. Sorry, I just thought of one other thing I could have put in my talk.
Sorry, go ahead.
If you don't mind, which is that there's sort of two main flavors of outpatient palliative care. There's either outpatient palliative care provided through a clinic that has largely a medical model. That's certainly the type of practice that I work in. And then there's outpatient palliative care programs that are run by home health agencies. So home health agencies are the folks who come out to the home and usually have nurses, physical therapists, occupational therapists, sometimes speech therapists, sometimes social workers that see people in the home. And those are kind of more practical support and sometimes emotional support. So there are home health agencies that have these offshoot palliative care programs that don't have a particularly medical focus. They might not have doctors who prescribe medicines on their team, but they're more focused on nursing care and practical guidance and emotional support. So I just wanted to mention that there's advantages and disadvantages to outpatient palliative care that has a more medical focus, and outpatient palliative care through a home health agency that doesn't have as much of that medical focus, but is in the home. I personally think there's a lot of advantages to have outpatient palliative care that's in the medical system, because we do a lot of work to coordinate care between primary care doctors and ALS teams, and helping people get their medications to manage symptoms. We, directly prescribe those medicines. But then again, of course, there's advantages to being seen in the home, and home health companies are more often set up to do that. So I just wanted to mention that.
Great, thank you.
Yeah.
So one of the next questions was about how some families can feel anxious about the possibility of being discharged from hospice if a patient has kind of been on that service for too long. So how can palliative care teams kind of prevent information to prevent any sort of withdrawal of hospice care?
Yeah, great question. So you're right. Unfortunately, sometimes hospice services have to end if someone has been found to have an extended prognosis, a prognosis of more than 6 months. Maybe they've ended up being more stable than expected when they were admitted to hospice. And because hospice is essentially an insurance benefit, and the hospice Medicare criteria is that you have to have a prognosis of less than 6 months. So if the hospice doctor can't say with confidence, and they are audited, they can't say you do have a prognosis less than 6 months and I can demonstrate it with all this data, and they can't keep you on their service, which is unfortunate if people have gotten really attached to their hospice team and have benefited from that support in the home. So we do sometimes get these referrals from people who have graduated off of hospice, and the hospice team can't keep them on service any longer, and they're looking for support until they progress further and can get back on hospice. And so I guess the role we've played in those cases is to try to approximate the hospice care as well as we can for someone who's been happy with their hospice care, and to try to be that extra layer of support for people during the period of time when they aren't able to be on hospice care. But if anyone's thinking this is all a little crazy, and like if someone's benefiting from the hospice care, why would we stop giving it to them? I agree with you completely. It's really unfortunate. Yeah.
Our next question is, why are some people put directly on palliative care at times right after they are first diagnosed? And the person who wrote it said that that was the case with the person that they're assisting.
Yeah. So it depends on the situation. Sometimes there might be a significant symptom. I don't know if it's pain or shortness of breath or some other symptom that the medical team, like the ALS team, might be looking for help from the palliative care team. So they might be, that might be the thought. Or if people present with respiratory failure early in the disease course, there might be a concern that this is a, really big change for somebody. It could be a rapid progression of the illness, and they may feel like we need all the support we can get. But some people might feel like that's not necessary, and that might have been the person who asked this question. They might have felt like this wasn't a type of care that they needed, or that they wanted to receive at that time. And kind of coming back to what I was saying a minute ago, like I realize it's super overwhelming to have lots of medical visits and all these different people to meet with, and what might be telling you slightly different things. And if it feels overwhelming, not what you need, not helpful, then of course I wouldn't continue palliative care. Yeah, so at the time there are very little symptoms.
Next question.
Interesting.
Right.
Sorry, go right ahead.
So next question is governed by funding. And so it seems that money can kind of determine a lot of the services that hospice care is able to provide. So is that true? And how do these centers, whether it's palliative care, hospice care, get the funding to actually provide support for patients?
Yeah. So hospice and palliative care are funded very differently. But to speak about hospice care, yes, it's an insurance benefit. Medicare pays the hospice team a certain number of dollars per day. It's like $154 per day or something on that order. Might have changed a little bit since I looked up that statistic. But so the hospice team is getting this direct payment from Medicare, and they have to provide all the care, medications, and equipment involved in the hospice care for that sum of money. So there are some things that unfortunately, just due to the finances, a hospice team can't provide. They do make exceptions, like providing tube feeds to people with ALS. Like that's not typically something a hospice team does. They don't do that for people with cancer, for example, but it's so important to people with ALS, if they can't eat, of course, that they provide that, even though it outstrips their budget by a lot. So yeah, it's a really tricky balance. Thankfully, in palliative care, we don't have those same considerations. We're, again, like a medical specialty where we get paid for our visits, but we don't get like a daily, $154 a day. You have to provide all the care, medical, medications and equipment for that cost necessarily. We just get paid for our visits. We prescribe the medicines. The medicines are covered by insurance. If we work with the ALS team to make sure you have the equipment you need, which again is usually covered by insurance. So it's a much more typical medical model in palliative care. But that being said, we do have to advocate like mad with our health systems. So for me, it's UCSF to try to get the social workers and the spiritual care providers and the nurses that I feel are really important to the care we provide, because the only person on the team who's able to bill for their services is the physician. But we strongly believe that palliative care is an interdisciplinary practice, and that it's better care if it is provided not just by a doctor, but by a nurse, social worker, and spiritual care provider all working together. So we try to make lots of arguments to our health system about the value of those people and why they're needed. And yeah, sometimes it feels more successful than others. It's definitely a tough moment for funding in general right now. No surprise.
Thank you. Our next question is, can you please differentiate between ALS ventilator care houses versus hospice inpatient?
Yeah, so there are very few ALS specific facilities. So those are few and far between. And I think they're great because they're specific to people with ALS and they have a lot of knowledge. But yeah, hospice care houses are not going to be specific to people with ALS. In fact, they're probably not caring for many people with ALS at all. It's very uncommon that a person with ALS is accepted into a care house like that, in part because people with ALS have such specific needs and specialized needs that the care house might not be familiar with delivering tube feeds and using non-invasive ventilation, other things like that. So that is part of the reason that most people with ALS receive hospice services at home. Yeah.
And we have one more question about access and insurance. I know you talked about it, but I think just a clarification on if you're a patient on Medicare, do you still need a doctor referral for palliative care?
You do, yes. Just like seeing a cardiologist or something like that. The insurance approval requires a referral. That doesn't mean that you can't, as a patient, call up an outpatient palliative care program and say, hi, I would like to be seen, or I'd like my family member to be seen. But they might say, can you reach out to your doctor for a referral? Or can we get your doctor's information? We'll reach out to them for a referral. So like our program allows self-referrals. People can call up and ask for an appointment, but we do in the background try to get a doctor's referral because we need that for insurance approval.
Now we have some specific care questions. What palliative care research studies are ongoing looking for non-opioid treatment for dyspnea?
Oh, that's great. That's great. Not as much as I'd like. We actually were just talking about a study idea in this area. So if anyone has a particular interest in this and would like to contribute or weigh in, would love to hear from them. But I would love to know more about how to best manage, dyspnea in people with ALS. I think there really hasn't been much research focused in that area specifically. We know that a big part of the treatment is adjusting the non-invasive ventilator optimally, which again is kind of an evidence-free zone. There's just not a lot of studies. And we also know that oxygen is usually not helpful. And despite the fact that it's often slapped on by emergency medical people or in an emergency department and sometimes in hospitals, people with ALS often get put on oxygen if they're short of breath, and that's usually doesn't address the problem. But of course, it's a complex issue, like decreasing aspiration, the saliva that's going down into one's lungs is an important aspect of preventing episodes of shortness of breath, just as another example. But opioids are also used for shortness of breath, I might mention. We think of them as pain medicines, but in low doses, they also are one of the classes of medicines that we turn to for shortness of breath. Yeah.
Thank you.
Yeah. Thank you
Next
so much.
question is, what do you think the role of palliative care, the palliative care team? Sorry, go ahead. There was a bit of a delay.
Oh, no, you go ahead. Sorry, I'm having trouble hearing you, but try again.
Okay, sure. So the next question is, what is the role of the palliative care team versus the ALS care team in terms of guidance for both hydration and feeding removal?
Removal. Okay. Stopping those things. To be honest, we usually don't stop the tube feeds or hydration unless people really, want to, and they feel like they don't want to prolong their life anymore because their quality of life has become unacceptable to them. But even in that situation, we would try to kind of aggressively palliate the symptoms more often than we would remove the feeding, the tube feeds or hydration. So we don't do that often, but occasionally people will say, I'm so miserable, my quality of life's not acceptable. I'm not on breathing support, so I can't remove that with a focus on comfort. So I instead want to stop eating and drinking, but that is uncommon. Just want to emphasize that. In those situations, we would very likely be involved because we'd want to make sure it'd be an end-of-life circumstance. So we want to make sure people's symptoms are palliated and treated aggressively and that the whole family gets a lot of support. Yeah.
Our next question is synapticure treatment considered palliative care?
Great question. No, currently they don't have a palliative care component. I met with them recently about palliative care and the possibility of integrating it into their services. And they seemed interested, but I haven't seen that come to fruition. So no, as of now, I don't think they have a palliative care specialist.
Right. One question we had was, are there other hospice practices in other countries, like in Canada or Japan, that you think or wish were applied in the US?
Yeah, that's a great question. Yes, I can't claim to be an expert in all of that, to be totally honest. But I think the UK is sort of where the hospice movement began, and they have a very well-established hospice program. And I think some of the changes that I'd love to see to our hospice program that I think are better in the UK is more respite caregiving hours or more help providing the direct hands-on care. And I sort of briefly touched on that on the hospice slide, but no member of the hospice team really comes out to provide the direct hands-on care in the home. They might have a personal care attendant who would come for like 2 hours twice a week to help with bathing, for example. I might change the bed sheets, but there's a lot about the direct hands-on care that falls to the family members. And I think in other countries, including the UK, there's a lot more like direct hands-on care that's provided by the hospice team and more caregiving hours. I think that would be a huge difference, or a huge improvement. Um, Another thing that I think would be really great in hospice is if they could provide the physical therapy, occupational therapy, speech therapy, respiratory therapy that some people with ALS really benefit from for the purpose of quality of life improvement. You know, it's sort of just an insurance accident that those things, you either receive your home health care with physical therapy, occupational therapy, etc., or you get hospice services, and you don't get both. And I feel like, why not? If people are benefiting from both, if that would improve their quality of life, then maybe we should provide that care. So that's another difference. I think in some other countries, there's not that restriction. And then I also might mention in pediatrics for kids, we have what's called concurrent care, which is hospice care from hospice programs, but it can be provided alongside life-prolonging treatments. So a little kid with cancer could be on chemotherapy for their cancer and seeing their oncologist, but also receive hospice care in the home that for kids actually involves an incredible breadth of services, usually pet therapy and music therapy, as well as support for the whole family, etc. And respite care and things like that. And you don't have to give up your life prolonging treatments, your access to oncologists and cancer treatments, for example. So people have talked about how we need concurrent care for adults too. And it's really just a financial issue. I think philosophically it makes all the sense in the world. Why not just provide people the most robust, comprehensive care possible? But it's really just a funding decision at this point.
Thank you. And I think we are at our final question. Are there any palliative care practices in cancer and other diseases that are not the current standard of care or in medical training that you think should be?
Well, one thing, this is a little bit, outside the major medical establishment. So I guess that's what the question was asking me about. But psychedelics are something that are being increasingly explored for different populations of people with serious illness. There's not yet robust evidence in all populations. So, for example, there's an ongoing study about psychedelics for people with ALS to see if that can help with depression or demoralization, which is kind of a feeling of hopelessness or fear of death, death anxiety. And the early findings are quite favorable, finding psychedelics to be very helpful. So that's just one example of something that's kind of outside the traditional medical armamentarium, but that holds promise and it's kind of interesting. Of course, there's other things like acupuncture, different types of body work, whether it's massage or Reiki or Rolfing, that also haven't been, explored and researched as thoroughly as I'd like. So those are a few ideas.
Thank you.
Yeah. Thank you all so much again for your
Thank you.
time and attention, these great questions.
Thank you, Kara. Kara, what did you think of those questions?
Oh, it's a great group of questions. Thank you so much. It really reflects on such deep thinking on this topic, and I so appreciate that. And by the way, I'm more than happy to share my slides, and I'd be more than happy to hear from any of you. I have my email on the last slide.
Okay, thank you, Kara. Thank you so much for everything you did today. Thank you.
For sure. Thank you
Thank you.
all. Take
As
care.
I mentioned, this program is recorded and it'll be out on our YouTube channel in case people want to share it with loved ones, with your care and support networks. There's some great information here. It's also discoverable in the mobile app as part of our interactive library. So we're going to hopefully get a lot of mileage out of Dr. Bischoff's contributions. And of course, Dr. Bischoff, if I'm sure you're amenable to any questions that continue to come in afterwards, we'll be back in touch with you to see what more we can do. And we certainly look forward to hearing more about the program you're developing with the ALS Association as well.
For sure. Thank you so much. Very sweet.
right,
Appreciate
well,
all the emojis.
You're welcome to stick around if you want. We're going to turn it back to the community, kind of talk amongst themselves now. And so McFinn, it's all yours.
All right, folks. Thank you, Kara.
Bye-bye.
Bye-bye.
Bye. Hey, folks, that was hands-on tonight. Is anybody having palliative care right now? No? Okay, well, I think palliative care is happening right here. For us just having this conversation, these are the kind of conversations that are homey because they come into your home with ideas about how can you actually help your caregiver